All right, we might get started. Okay, so good morning, everyone. My name is Yishim Karasu. I am the Mind Out Project Officer for LGBTQI+ Health Australia. The Mind Out team is all about mental health and suicide prevention initiatives. Today, we're hosting a webinar to discuss a report out of the Australian Research Centre in Sex, Health and Society. We've got some lovely panelists. Unfortunately, Anna Berensochi cannot be here with us today, but we'll introduce you to the other panelists later on, as well as we've got some insights from a lived experience expert, as well as a service manager in the LGBTQI+ suicide prevention space. But before we get into all of that, I'd like to share a pre-recorded welcome to country from Donna Ingram. Donna is a cultural representative from the local Aboriginal community in Sydney. Donna's Aboriginal family connections are the Wiradjuri of the Central West New South Wales. She is a mother of 4 adult children and a grandmother of 5. She was born and raised in Gadigal land. Here's Donna.
Hello, everyone. It's my great pleasure to be here with permission from my elders to offer you welcome to country from Mind Out's webinar to report on the findings from the Lean On Me report, exploring suicide prevention and mental health related peer support in Melbourne's LGBTQ communities. It gives me pride to represent my community in this important cultural protocol. It shows respect for and recognition to the unique position of Aboriginal and Torres Strait Islander people in Australian culture and history. We are presenting to you from the traditional land of the Gadigal, who are one of 29 clans of the Eora Nation, which is bordered by the Hawkesbury, the Georges and the Nepean rivers. I'm an Aboriginal woman who proudly identifies with the Wiradjuri Nation through my family connections from Central West New South Wales. I was born on Gadigal land and I've had the privilege to live, work and raise my 4 children on this land for most of my life. My family has grown and I'm now a proud grandmother to Aaliyah, Elijah, Kalila, Lakota, Jake Jr. and Archie. My wish for my grandchildren is to grow up happy and healthy in a safe and inclusive society that offers them equal opportunities regardless of their race, their gender or their sexuality. I acknowledge the Gadigal and all spirits represented today. Their spirits and ancestors will always remain with the land Mother Earth, and I thank them for their ongoing custodianship. I pay my respects to our elders, both past and present. We must never forget the sacrifices made by our leaders to create a better future for Aboriginal people. I do this as a reminder and a tribute to elders and those who have gone before us to fight for land rights, justice and equity for our communities. I extend my respects to Aboriginal and Torres Strait Islander people from all clans and nations who are viewing this morning. I also recognise our non-Aboriginal sisters and brothers who walk beside us to support each other during a mental health crisis. At this point, I would normally say I now offer you a warm and sincere welcome to the land of the Gadigal of the Eora Nation and wish you a safe stay on the land and safe travel from the land. I have the same wish for you all, whichever country you may be viewing from. On behalf of my community and the Gadigal, I wish you an interesting and informative time hearing about the findings of this report and the panel that will explore the ways that suicide prevention and mental health related peer support is extensive and vital in LGBTQ communities in Melbourne. In closing, we remember that this is, was, and always will be Aboriginal land. Thanks everyone, have a great day.
Thank you, Donna, for your welcome to country. Today, I'm on Gadigal land, zooming in. I'm aware that there are many people on other different lands. It's very nice to be sharing space with you all and very nice to be shining a light on some important research. The Lean On Me report came out of Melbourne down in Naarm. However, it's echoing nationwide evidence. And this evidence is that there's a gap in mainstream services' ability to engage and maintain LGBTQI+ clients. This is a gap that our community is filling with informal peer support. The report finds that LGBTQ people are providing support to friends, housemates, partners, or even general acquaintances in terms of suicide prevention and crisis support, and that this is often leading to burnout. The report makes recommendations on how to support the LGBT community from burning out, as well as how to make mainstream services more accessible and desirable to our community in the first place, who are desperately needing this support. We're going to be talking a lot about mental health and suicide today. We know that our community is deeply impacted by mental health and suicide. I want you to remember to take a break if you need, get a cup of tea, or just have a moment for yourself throughout the webinar. Maybe a good idea to take some time out after the webinar to do something nice for yourself. We're also going to be posting some links to helpline services in the chat, including QLife, which is LGBTQI+ specific. The MindOut team would like you to know that if you are affected by any of the content today, we see you, we hear you, and you're not alone. In saying that, I'm going to hand it over to Amber to introduce our panelists. We'll have a brief panel discussion, look at a service statement, as well as a lived experience statement a little later on. But for now, Amber Loomis is our wonderful policy and research coordinator. They'll be moderating the panel today. Amber, I'll let you take it away.
Thank you so much for the warm welcome, Yushim. I'll just begin by acknowledging that I'm zooming in today from Darugland, and I'd like to pay my respect to elders past and present. As Donna so wonderfully reminded us, this always was and always will be Aboriginal land. I'm really honored to be here today in conversation with Dr. Adam Bourne, Dr. Andrea Whaling, and Joe Reed to dive a little deeper into the Lean On Me report. So I'll just invite our panelists to join us on screen, and I'll introduce each of you, and then we'll go ahead and kick off our conversation. So Adam Bourne is Associate Professor of Public Health and Deputy Director of the Australian Research Centre in Sex, Health and Society at La Trobe University, where he leads a large program of research relating to LGBTIQ health and well-being. He has a particular focus on research into mental health and suicidality, alcohol and other drug use, and family violence. Adam is a member of the Victorian Whole of Government LGBTIQ Task Force and co-chairs its LGBTIQ Health and Human Services Committee. We're also joined by Dr. Andrea Whaling, who is an Australian Research Council DECRA Fellow at the Australian Research Centre in Sex, Health and Society. She is currently working across a range of research projects involving explorations of men, sexuality and bodies, young people and sexual literacy, technologies, sex and sexual intimacy, and LGBTIQ health and well-being. And last but certainly not least, we're also joined by Joe Reed, who is the Project Officer for Suicide Prevention at Northwestern Melbourne Primary Health Network. Joe has led the LGBTIQ suicide prevention trial for the past 2 years, co-designing suicide prevention activities with LGBTIQ communities, people with lived experience, community-controlled organization, and health organizations. And this also includes the Lean On Me report. And you could probably hear my dog joining in too. My dog's excited to learn about the report too. So thank you to each of you for joining us today. This is a really, really incredible opportunity for us to chat a bit more about this report. And what a staunch group of researchers and practitioners to be here with us today. So to kick us off, Adam, can you talk a little bit more about some of the key findings from this report?
Sure thing. Thanks, Amber. And I'd like to acknowledge that I'm joining you all today from the glorious lands of the Wurundjeri people of the Kulin Nation, and I similarly pay my respects to elders past, present, and emerging. I'm really grateful to LHA for hosting this webinar and giving us the opportunity to share a little more the findings from the Lean On Me study. Lean On Me was really about trying to understand how do peers within the LGBTIQ communities, how do they support one another through times of really pronounced and really challenging mental health crises. We know that mental ill health is so astonishingly high among our communities. We hear that time and time again with different kinds of surveys. And We also know that many LGBTQA+ people struggle to access affirming mental health services that are culturally safe environments for them to talk about their lives and talk about the challenges that they're experiencing. So what's happening as a consequence of those two issues is many people within our communities turn to one another for support instead, because they're not able to access, or not always able to access, that professional support that they might need elsewhere. And I guess on some level, that's something we should really celebrate. Like, we should celebrate the fact that we are a kind of community where people can turn to support for one another, where there is acceptance and trust and love among the community that is willing to step up and perform that role. Like, I think, you know, let's celebrate the fact that this is a really wonderful part of our community. I think what we documented and what we heard so often in Lean On Me, in the interviews we did for Lean On Me, was just how challenging that can be on an ongoing basis. If you're constantly within a community or within a setting where you're always having to shoulder that emotional distress that other people are hearing, if you're always trying to hold other people up, then that itself can be a really, really challenging thing to deal with yourself. It's having an impact on your mental health, on your sense of self. It's leading to burnout, and, you know, having a wider negative impact on other aspects of your life as well sometimes. And that was, I guess, one of the key things we were really documenting in this report.
That's a really fantastic summary. Thanks for that, Adam. I want to pick up a little bit more about some of those challenges that emerged in your research. Andrea, would you be able to talk a little bit more about some of the insights from participants around those challenges? And were there any differences between groups that may have emerged that maybe surprised you at all?
Sure. I'd just like to also take a moment to acknowledge that I'm also speaking on the land of the Wurundjeri people of the Kulin Nation and pay my respects to their elders past and present. I can talk a little bit about some of the major findings in terms of the kind of specifics per group. I think I'll hand that back to Adam to kind of fill some of that information in. Some of the challenges that we found was that a number of people were providing quite a lot of support. In fact, they were providing support in dozens of situations for someone who is experiencing suicidal ideation or distress. And that a lot of the support also came through over a number of years, or providing support to an individual over a long period of time. So there's quite a lot of burden for this community in providing some of that support. We also found that there was a lot of experiences of burnout and feeling distressed from that burnout, and feeling that participants were often talked about struggling to cope at times, feeling worried that if they weren't there for a friend or a partner or a colleague, that someone else may not be there. They were concerned about mental health rates more generally in their community, being witness to a lot of that. And they were also concerned about just their own mental health and well-being, that they were struggling at times with themselves. Adam, did you want to talk a little bit about some of the specifics for groups?
Yeah, sure thing. So I think one thing that was really evident in the 30 or so interviews that we conducted in the project was how diverse this experience of providing peer support was. And we came up with these, we called them typologies, which is a overly grand way of describing just different kinds of groupings of people who are having similar experiences. So, we talked about people who were seen as the safe friend within their community or within their friendship group. Like, there's a group of friends who will come together, socialize together on a regular basis, but there's that one person who is known within that friendship group to be, particularly empathic, particularly approachable, and often that person ending up being on call for those in need within their friendship group on a pretty regular basis. And again, like, many of them were really celebrating the fact that they were performing that role, but they were often finding it quite hard to take a step back if that distress was ongoing. And as Andrea was pointing to, it's really, really hard when you're faced with a scenario where friends around you are in really, really difficult mental health circumstances. But that's over time having a really big impact on you. It's really, really hard to take a step back from that situation because you worry so much about what might happen if you kind of step away from them and the very vulnerable position it might leave them in. So there was the kind of the idea of this safe friend. There is the idea of the housemate, and a lot of the sample a lot of people we interviewed were younger people who were living in share house type situations, and quite a few of them describing occasions where they were living with other members of the LGBTIQ community who were in very pronounced mental health difficulties. And they were doing their very best to try to support them in these periods, but it was really, really hard to draw a boundary around that when it was in their home. Like they often didn't necessarily find the cognitive escape or the safe space that they needed to help maintain their own mental health when they were living with people on, dealing with it on a kind of everyday basis. There were the people who were working, a separate group were people like we called them the help worker. So often these were people who were working sometimes within LGBT community organizations, sometimes within other kinds of mental health or peer support organizations. And they were doing that in their work time. And then people in their social time looked at them and thought, okay, this is someone I can talk to because this is an area that they are an expert in. And of course, they were willing and keen to provide that support whenever they could. But, they talked about this notion of having to work the double shift. They were having to do all this kind of work, holding up their community in the daytime and then clocking off and doing it in the evenings and weekends as well. And that just becoming really unsustainable over time. We heard from the people who were the partner was another type we talked about. And actually, we have to recognize that peer support within our communities can also be to a romantic, a more intimate partner as well. It's not just about non-romantic partners, but sometimes that could morph into feeling more like a caring kind of role rather than necessarily romantic or intimate partner role. We heard about the friendship circle. It's not always just one person who's providing this role, but sometimes it's a group of people who come together to help provide support around a person, particularly at really acute periods of mental ill health. So particularly at points where someone had attempted suicide, for example, and there's a group of friends who come together to try to support the people in that circumstance. So it was a mixture of really creative situations and really diverse people and types of people and different types of situations who came together providing this kinds of support. And they all faced different kinds of challenges depending on the point they were in their lives, the physical situation or the relationship situation that they were in.
Thanks, Adam. That paints such a really rich picture of those different experiences. Joe, is there anything that you'd like to reflect on in relation to the findings from this report?
Hi, thanks, Amber. Firstly, I'd just like to acknowledge the traditional owners of the land that I'm on, which is the Wurundjeri people, the Bunurong people, and the Wannerong people, and pay my respects to elders past and present. Yeah, so actually listening to Adam and Andrea, the reflection is that we, as part of the trial, knew of, or hearing of this informal care network that was within our community, and obviously the real need to understand more about that. And I think what it's shown is that it's even more complex than we thought. And it's really given, and this research is actually given some really specific groups of people, and they need different support at different times. So it's not a one size fits all to supporting our community and people in our community who are providing this support. So I think it's really demonstrated that there's a whole, underworld of support that it's not being recognised, and people, it's really, yes, on one hand is really, really helpful, and this report is showing that it is actually saving lives, but it's also having a really negative impact on some.
Thanks, Jo. Now, Adam, before you talked a little bit about the really wonderful part of being able to be in a community and support your peers. And so far, we've talked quite a bit about some of the challenges that emerge in this peer support network work. Is there anything, any of the positive benefits that you might like to talk about that came through in the work that you've done?
Yeah, sure. And I'm glad you asked, because it's so easy to paint a very pathologizing picture in relation to mental health in our community. And I look for any opportunity to talk up kind of, mental health experiences that aren't necessarily always so negative. Yeah, look, I think that, a range of people just finding tremendous value in the ability to support others within their community. Like, recognizing, yeah, I find this draining. Yeah, you know what? I find this really hard to handle and to carry this weight of all these different kinds of emotions from others, and that I'm trying my best to grapple with right now. But I really value that I'm able to do this. I value that I can play a part in my community, that I can contribute something meaningful, that I can try to bring about positive and affirming change for my community. And there were quite an interesting number of people who talked about how they see this has been a pathway for them in entering into more professionalized therapeutic and counseling support, or they have an aspiration to in the future. So there were quite a few people who told us about the journey they've been on. I talked a moment ago about those different typologies of people. Now, the reality is, people could have held all sorts of those different typologies, those different roles at different points in time. They may have been the housemate when they were younger. They may have been the help worker now. And we saw that quite often. There were people who described, they'd spent years when they were younger helping to support friends in very informal ways, recognized that actually they felt they were quite good at it. They felt that they were quite good at being empathic. They felt that this was a skill that they've been able to develop and harness over time, and they valued being able to make that contribution. And so they actually entered into, things like formal trained volunteer roles with organizations such as Switchboard or other providers of Q-Life services. Or indeed, then they stepped into formal counselling training, even going on to do degrees in social work among a handful of participants. So a kind of really nice trajectory that some people found themselves on, I guess I'd say as well. But being that feeling like they can make a positive impact on their community, let's not diminish the importance of that. Like, some people can derive huge benefit from it. And we actually know from other research that feeling connected to community and volunteering in itself can have a positive association with one's own mental health. And obviously there's a balance to be struck there, for all the reasons we've talked about, but we know that these can be really affirming things as well.
That's absolutely a key theme that I want to come back to. But for now, I'm going to go ahead and pass back to Yashim, who is going to introduce a lived experience video, and then we'll be back soon to discuss further.
Thank you so much, Amber, and thank you, panelists. You're doing an amazing job. I want to bring into focus a lived experience statement. And I think it speaks to the diversity of stories that Adam was touching on. This is one story of lived experience, story of providing that peer support. Martha Jane Latham is speaking to her experience providing mental health support to her family as well as her partner, and what that means to her as a queer woman. Martha, or MJ Latham, is an emerging theatre maker and creative. She believes in collaborative and upstream theatre making with a focus on creating works that are relevant and interesting to young people. Here's Martha.
Hi, my name is Martha Latham. My pronouns are she, her, and I'm going to talk about my informal experience assisting friends and family members with their mental health. I think a really clear example of some of the ways in which I assist people with their mental health was last year during the 2020 COVID-19 pandemic. My brother had recently come back from Canada. He was just in a really vulnerable position at the time. So at first, I was quite busy. I was studying my master's degree at the time, and so I wasn't really able to be there for my brother as much as I would like. But the more and more I noticed him becoming frustrated with the assistance or the help that I suppose my other family members or his other friends were offering him, the more that I reached out to him on digital platforms, such as Facebook or just even over text, to see how he was doing and to offer help and just to listen to him. And I think really this is kind of a key thing that happens a lot, is often I'm really willing to invite people into conversation in really informal ways and spaces. Especially I think the digital medium and text is such a great way for people to be able to open up and talk about exactly how they're feeling in a way that doesn't feel quite so terse or complex as speaking in person. Some of the other ways that I've found that I've helped some friends and family members has been I often, my partner, after she finishes her therapy sessions, I'll often end up having almost an post-therapy session where we kind of just talk about what it was that they talked about in the session and what it was that she learned and the things that she's been thinking about or that the session has made her think about. Often I'll find people that I don't really know reaching out to me, but also I reach out to a lot of people as well. And I find I end up in lots of situations where I think, I've got too much on my plate because, we've been going through this complex pandemic and I've taken the time every month or so to reach out and check in with people and ask how they're doing and how they're feeling. Because I think I know what it feels like to be isolated. And I really do think there's a joy in getting to help people in what they're going through, especially if I have the energy to and the ability to. I think too often we leave people to their own devices. That's when things get really difficult. Do I think that myself as a queer woman, why do I find myself ending up in this circumstance so often? And I think first and foremost it's because I know what it's like to have to struggle with these kinds of anxieties and stresses, and I've lived with depression almost my entire life. So in many ways I know exactly what it takes to get out of those feelings, but also I know how hard it is when you're within them. I know what it's like to have those feelings where you can't feel like you can't communicate properly, and so you struggle to tell someone exactly how it is that you feel, and you just need someone to sit there with you while you work it out. And I know how important that can be. And secondly, I think it's because I really do also know what it's like and how useful it can be for someone else to reach out to you and to do a lot of that work. So I think having experienced those things myself, it makes me much more open to hearing it from other people and to understanding their perspective. An analogy that a friend told me recently that I think is quite relevant was that when we think about breaking down mental health walls, we think about it like smashing down a brick wall with a sledgehammer, when in reality it's more like slowly picking away gently, and it takes a long time. It's about finding those cracks at first, and then peeling away what you can with your fingernails, and eventually someone offers you a tool and you can start to use that and things get a lot easier. So I think because I've been through a lot of these stresses and foundations, and I think a lot of other queer people have been through these kinds of depressions and stresses and anxieties, we already have those tools available. So we end up assisting others because we have those tools on offer to them. I think really that's what makes it so important, that we have this beautiful community that is able to reach out and assist each other. And it also is so beneficial when, especially in times like these, accessing professional mental health care can be so difficult and also daunting a task. You have to go through the medical community, you have to prove that you are in some way mentally ill. It can be quite challenging, but really all you need is just a little bit of help. So that's a brief overview of my experience. I really appreciate you taking the time to listen. Don't be afraid to reach out.
So that was Martha Jane. I'm going to pass it back to Amber and our panel. But thank you, Martha, for your words.
Thanks, Yishin and Martha. That's my dog again. I'm going to go ahead and perhaps start with Joe. After listening to Martha's reflections, in what ways can we center the lived experience and in peer work and suicide prevention?
Thanks, Amber. I don't have any dogs today, so we're safe with me. Yeah, look, I think that is probably the biggest question you can ask in relation to suicide prevention. What we've learned over the life of the trial is lived experience must be at the forefront of everything that we do. But we must listen. We must provide a diversity of voices across our whole community, as well as intersectionalities. But when we listen, don't just ask, listen, and then act. We need to act on what people are saying. So I think by providing some really evidence-based to decisions that we're making, and with the lived experience voice actually at the forefront, like this research project, we can then say this is the evidence and this is what we need to do. So unfortunately, there's not a lot of evidence for suicide prevention for LGBTIQ plus communities. So this is just adding to that.
Absolutely. Andrea, do you have anything you'd like to add building off of what Joe has said there?
Yeah, look, I think centering lived experience is the most important thing that you can do when it comes to supporting the community with mental health distress and suicidal ideation. We know from plenty of research that accessing health services can be a very vulnerable and traumatic and trying time for people. And so going to peer support is often where they'll turn to. So it's also about not just centering the lived experience, but using that to then find the best ways to actually support peer supporters in helping them support their community and their friends. And that includes things like ensuring that we can support them to not only provide the support they need to give to their family and friends and other partners, but also helping them draw boundaries around themselves and how to protect themselves when they need to, and how to kind of set some of those things in place as well. Yeah, that's probably what I would say.
Amber, could I just maybe add to the just briefly on top of points from Joe and Andrea, which I entirely affirm in every possible way. I guess just the thing I'm always keen to emphasize around lived experience, particularly in relation to mental health, but I guess the same is true in any sector, is that when we're talking about lived experience among LGBTIQ communities, we just have to be recognizing the considerable diversity within our communities. I think the PHN where Joe works has been an absolutely admirable example of where they've done this really well, trying to draw together lived experience voices from all different kinds of sections of the LGBTIQ community across the range of genders and sexualities, as well as a whole range of other intersecting characteristics. I think where I often see it done not as well is where there is a lived experience voice from LGBTIQ communities, and it's a token person who happens to be gay or lesbian more often, I would say. And while that is, of course, really valuable in and of itself, that one person can't speak to the very broad range and very disparate kinds of experiences that different sections of our kind of queer rainbow community have. So lived experience has to attend to that kind of diversity. Like there's a lived experience of mental health, which is hugely important, and there is lived experience of being a member of the kind of rainbow community. And those are the two things that we always have to try to hold in the balance. Like I said, I think Northwest and Melbourne PHN did a great job in that. But it's just not always, it doesn't always play out as well as perhaps it needs to.
Absolutely. And I'm glad that that's something that you brought up, and I'd like to unpack that a little bit more. And I'll maybe start with Joe on this one. Can you maybe provide some some examples as to how what Adam has touched on has played out in the work that you're doing?
Yeah, sure. So we've been working with the community for 5 years in the suicide prevention trial, part of the National Suicide Prevention initiatives. And lived experience, it's either lived experience as a person of the community, have been invited to be a part of any of the initiatives that we've done, so especially a task force that we developed. So people with lived experience as well as from the community, but also people with lived experience from our community, as we've said, work a lot within our the mental health system, suicide prevention, and other community controlled orgs. So there's always been a crossover of lived experience there. But we're also trying to embed the lived experience within the organisation. So within it's a commissioning organisation, not only saying, okay, well, once we decide what's happened, you need, you can come and then be that person, that token person. No, it's actually people with lived experience are actually designing the activities. So, and they're part of our commissioning process. They'll sit on tender panels, and they'll provide expert advice. And we really see the importance of lifting the voice of the transgender, diverse, non-binary communities, because we know that unfortunately, the impact on the community of suicide is really, traumatic, and we so value those voices.
Thanks for that, Jill. And I know just a little bit later, we'll have an opportunity to talk a little bit more about what this looks like from the service side. So I think that provides us with a really good starting place to take those conversations later on. Andrea, I'm just going to pass over to you, and I'm curious to know a little bit more about some of those key differences that we see relating to mental health across LGBTIQ plus communities. And if you can talk a little bit more about some of the differences and experiences that we see there.
Sure. By differences, do you mean by different population groups? Is that what you're referring to? Okay, so we know, for example, that trans and gender diverse and non-binary people will often have very high rates of mental health distress in comparison to other groups. And that's often due to the kind of the trauma and the discrimination they experience as a result of gender discrimination. And we also know that bisexual, pansexual, polysexual people also experience very high rates of mental health distress and potential suicidal ideation as well, due to a lot of misinformation and discrimination, particularly around sexual orientation and identities. And a lot of that can be compounded when it comes not only just from what we might call mainstream or heterosexual and cisgender community, but also can be found within LGBTIQA plus community as well. And so those are some of the key differences that we see. And the other thing that we also see is a lack of sometimes support for some of those population groups. It can be very difficult for them to access affirming, culturally sensitive, and validating services that actually understand some of the complexities around what it means to be a trans or gender diverse person, or what it means to be a bisexual or pansexual or polysexual person. So those are some of the kind of key differences that we do see. And as a result, they're often kind of left in what we might call a limbo, where they're trying to find affirming support that is there for them, that helps them out. And this can be across the entire community, but we know that those are some of the highest rates that we're seeing are kind of within those groups.
Fantastic. Thanks for that, Andrea. Adam, are any of those differences that Andrea has talked about, did those come up in the Lean On Me work at all?
Yeah, definitely. I mean, particularly just to underscore the point around the particularly challenging circumstances for many trans and gender diverse people. There was an interesting quote from one participant talking about how, the mental health support system was a house of cards built on a house of cards. So, people who are trying to hold other people up and are trying their best to support them are themselves often already in some quite challenging mental health circumstances. And that, I think, was especially true among trans and gender diverse people. I think we know, sadly, as Andrea was just outlining, that many trans people are considerably more likely to experience mental health distress. That's because very, very much because of the appalling experiences they have in relation to stigma, discrimination, violence, and abuse on the basis of the gender identity. And we also know that they're even more likely to experience challenges accessing affirming mental health support. We did a project a few years ago, Andrea and I, a project called LGBTIQ Lives in Crisis, looking at people's experiences of accessing mental health crisis support lines. And Andrea can talk more confidently to some of the findings than me, but I remember there being, you know, a huge number of trans and gender diverse people just talking about, you know, the most basic things, saying, at the point at which I'm feeling suicidal, I do not want to be having to educate the person on the other end of the phone about what it means to be trans or what it means to be non-binary. This is not the moment for me to be educating you. Sorry, I'm going off topic slightly, Amber, but I guess I was just trying to emphasize that the challenge that many trans and gender diverse people were faced with, and why then it was the case that so many were having to return to one another for that kind of peer support instead. But that was really challenging when their own mental health was often precarious at times, to say the least.
That makes perfect sense. And that imagery of house of cards on a house of cards is so, so powerful. And I think that ties in a little bit to what Martha was speaking about in her video. I've just seen that we've had a question pop through. Do any of you know if this work is being replicated in other states? And if so, what is being done?
I'm not aware of it being replicated yet. I mean, we would love to see that happen. I think we've had all sorts of ideas around how and where we'd like to take the project next, and what how we could expand upon it. Not quite landed or being able to make that possible yet, but you know, we live in hope that such things might become possible. I guess I would just say, I mean, maybe the findings are Melbourne specific, and I guess it's important to note that a lot of the data was collected during Melbourne's very pronounced COVID-19 lockdown last year. That said, many of the experiences had nothing to do with COVID, or people had those experiences prior to COVID-19 emerging. But I think, I mean, I might be wrong, and this would be interesting and valuable, of course, to conduct it in other states. But from talking to colleagues in Sydney, in Perth, in Brisbane, for example, like I get the sense that many of the findings feel quite similar to stories we hear in other metropolitan areas. That's not to say that there wouldn't be nuance in the experience. Of course, I'm sure there would be. I think what we would really like to see is expanding this work into more rural and remote locations in particular, to see if and how these kinds of experiences are kind of reflected in very, very different kinds of communities, where there isn't necessarily access to the same kinds of social spaces or cultural spaces for queer communities, where the availability of affirming LGBTIQ mental health services is diminished as well. So I think there's lots of reasons to want to kind of open it up in other spaces. But we haven't been able to do it yet, I guess, in answer to the question. I'm not aware of anyone else doing it yet.
And I think perhaps that speaks to the importance of what was mentioned earlier around taking into consideration the diversity within LGBTIQ+ communities, and making sure that in whatever lived experience work you're doing, where possible, that diversity is reflected when you look at expanding this work into other places. So thanks so much for your question there. Yeshim, I'm going to go ahead and bring you back. We've got another pre-recorded statement that we'll go ahead and give a listen to, and then I'll bring the panel back for one final chat before we wrap up.
Absolutely. Thank you, Amber. Thank you, Andrea, Joe, and Adam. I'm going to now share a service statement from Isabel McGovern. So Isabel McGovern is going to be talking about peer support services. Izzy, who uses they and she pronouns, manages Aftercare, a peer-led suicide prevention service in Melbourne. Izzy touches on what makes aftercare successful as a peer-led service in suicide prevention, as well as advice to other services who might be considering how they can better support peer workers, or to how they can start to enact some of the recommendations out of the Lean On Me report.
Hi, my name is Isabel McGovern. I'm the lead of the aftercare project from Mind Australia, and we are dialing in from Naarm, so-called Melbourne, on the unceded lands of the Wurundjeri and Bunurong people of the Kulin Nation. We provide care for 3 months for LGBTIQA+ people with thoughts of suicide. And our program is in many ways peer run and peer led. So that includes myself. I identify with being both queer and having a lived experience of depression, the thoughts of suicide myself. And we, I guess, operate more on a community-based model than a strictly clinical model, although we do provide psychological care as well through our psychologists. Referrals come in through a form that you can download from our website. People can self-refer. Some referrals also come from other services. We have people who might be coming straight from hospital or sometimes the HOPE program. But we also have people who may have lived with thoughts of suicide for quite some time and who want to receive support now in a kind of preventative way. Definitely a theme that I've noticed in the queer community, at least, of either not feeling suicidal enough or feeling too suicidal, and thereby people almost like self-exclude from receiving care. And I think that has a lot to do with internalized stigma and probably a lot of other factors. But we emphasize to folks as a result that you can engage with us in a preventative way, that however you are, is enough in order to receive care from your community. We want to welcome people into our space as part of welcoming them into the community. We know that isolation and sense of disconnection from others is a really big driver of thoughts of suicide. And so by having a space that is explicitly LGBTIQA+, as well as a space where you know that the people around you have also shared similar experiences to you. You can kind of experience this kind of a solidarity and a sense of being seen in a way that might be unavailable in other spaces where people receive care for thoughts of suicide. Peer practitioners are really at the heart of Aftercare's program, and that matching process is quite important too. Just because someone shares the same categorical experience as you doesn't necessarily mean that you're going to get along. And so that there's a great deal of thoughtfulness that we try and put in to that matching process. And people can also specify, like, if there's a particular gender that they feel more comfortable working with, or someone of a similar age to them as well. We take that into consideration. So things that have allowed us to be successful in this space. So having peers with lived experience, again, they're just absolutely critical. Relationships are crucial to the long-term success of any aftercare project, I think. We need to actively nurture our community, and we do that through other human beings. I think that what makes us different from other mental health organizations is that not many other larger mental health organizations who are providing support to LGBTIQA+ communities have a dedicated space where everyone as part of that service is LGBTIQA+ identifying. Oftentimes it's about changing the intake forms a little bit, or like maybe having an advocate somewhere in the organization, but to create something of an enclave which has a degree of autonomy and trust by the organization is really important. I think that we need to constantly be on the lookout for tokenism, and I think that the way that aftercare has been kind of given that kind of support by the organization to provide our own care for our own community rather than assuming what we need has been absolutely critical. I think as well, like peer workers are often structurally a bit at the bottom of the hierarchy. We have to kind of prove our usefulness in some way. And there's pressures of the role. It's often like quite a new role within organizations. There's limited historical context for peer work. And there's like very little mentorship, I think, for peer work. There is some, there's been some real pioneers in the peer work space, over the decades, but by and large, peer workers are often kind of these little satellites, isolated, and people are unsure about what their role is and so on. I think that there's often a lot of trauma that people have experienced in clinical spaces, particularly for our trans and intersex communities. And there's much as we can do to dismantle some of those signifiers, the better in my view. When people have experienced discrimination, we have to consider about what kind of circumstances that discrimination took place in, and how, as a service, if we're looking to do genuine healing work, we can like dismantle some of those dynamics and cues. We had some really key allies to our project within the organization, particularly the Allied Health Business Manager. And he was able to provide some technical skills building support for me, who was very new to figuring out what a budget was. And he was also there to be an advocate within the organization too, as were a few other key players. So that meant that we were able to deliver the service that we envisioned and not necessarily a vision that was imposed upon us. I do think that if an organization was considering starting up an aftercare project and wanted to then micromanage it and kind of superimpose their vision of what LGBTIQA plus community care looked like without being part of the community, the wheels would probably fall off. You have to listen to the people, and you have to listen to what the workers are saying and trust the people on the ground. And I think that that's what has really happened. It's a key driver of success. Yes. Oftentimes people are coming to the program feeling really isolated, and to be able to provide that sense of connection and you are not alone in this, and that was not okay. And those experiences of homophobia, of transphobia, of biphobia that you may have experienced in services, but also just over the course of your life, that makes, it makes sense to be in this amount of pain. And I think that through that, we've been able to do really kind of practical work that requires like a degree of mutual trust. The barriers starting up were about uncertainty about how do we even do this thing. There's not a whole lot of models to easily kind of go off, especially ones that are delivered by more mainstream services or that aren't just like total grassroots community collective responses, such as Discharged, who are doing amazing work in NWA. So it was about kind of fine-tuning this hybrid model. Now we have fine-tuned that hybrid model. It is more like so many things about receiving ongoing funding, the golden egg of all mental health and social support services. So I do think that we need to receive continuous community care, and in order to really grow something, it's really difficult to be jumping from funding cycle to funding cycle. Advice for other services, I would say partner with an LGBTIQA plus organization. You need to develop strong relationships with the LGBTIQA plus community. Trust is everything. I would say support staff, ensure that they are feeling like they have a sense of say and control within how a program like aftercare is delivered. I think it's important to have solidarity. So make sure that if you are going to hire a peer worker, don't just hire one peer worker. Make sure that you are hiring several peer workers. Again, they've been at the bottom of the hierarchy in the past, and we need each other. So yeah, I think that's important too. I think if I was to give advice to other people managing similar programs or mental health programs more broadly and working with peer workers, I would say don't conflate good worker with like assimilation into the existing company norms. Particularly for peer workers, there is a kind of peer worker culture that needs to be respected. And for LGBTIQA plus workers, it's the same again. It's actually about really being prepared to change the whole way that you work. And that means giving up power to a certain extent, which might be really confronting. But I think that it needs to land again back into the hands of people providing that care. If we're going to really transform this sector, that involves both a deep listening and then a willingness to do that deep work.
Thanks, Yashim. It's really heartening to hear so much of what we've talked about in our panel so far reflected in those really brilliant insights from Isabel. So thank you so much to Isabel for adding into our conversation today. And I think that at this point, I'm really keen to explore in more depth what this report means for service provision. And I know we've started going there a little bit with what Joe had commented on earlier, but if we can dive into that a little bit deeper. Andrea, perhaps we'll start with you and then we'll go over to Joe. How can the Lean On Me report be used to offer better service delivery?
Thank you. I think the first thing that we can take away from the report that a lot more needs to be done than what's being done at this time. We know that community organizations and health services and mental health professionals should be adequately equipped and funded to support this community. And this includes resources and funding to support not just mainstream health services, but making sure that we're supporting and funding our LGBTIQA plus special services as well. In terms of mainstream services, it also means making sure that we're reaching out to services in regional and rural areas where there, as Adam mentioned earlier, there may not be the possibility to have an LGBTIQA plus special service in every country town and every regional center, but having services that are mainstream. And that can also create a sense of safety as well for people who may not feel that they can access an LGBTIQA plus service for whatever reason. Maybe they don't live in a home environment where it's safe for them to do so, then they don't feel quite ready. A mainstream services that is adequately trained in supporting this population group could be a really great way in for them. It can be, you know, an affirming and positive experience. We also emphasize the importance of a commitment, a collective commitment from various levels of government and public health networks and community organizations to achieve better mental health outcomes for our LGBTQ communities, and in making calls to kind of help to the capacity to enhance the support. So this includes, you know, thinking about the contributors to mental health that should be addressed. That includes addressing things like discrimination and violence and stigma, as well as kind of prioritizing communities that experience higher levels of mental health distress, and considering kind of different types of prevention that can help do this, but also thinking about varying ways in which we can support people through crisis situations, supporting them in that role, helping them respond to active suicidal ideation, referring people to services that can help in that regard. So those are some of the things that I would kind of say are really important takeaways from this report, that we need to do more to support this community. And one big fundamental message is that the majority of support is coming from peer support, to support their colleagues, their friends, their partners, their family. So much of that is such a burden. Financially, it's a burden, it's an emotional burden, it's a mental and physical health burden, and we need to do more to support this community, and that needs to come from government, it needs to come from funded institutions to provide some of that and to take some of that burden away.
Jo, is there anything that you'd like to add into that?
Yeah, sure. Look, yeah, I totally agree with everything that Andrea just said. I guess what I can offer here is something of a how can services maybe improve what they're currently doing, and what work is being done at our PHN and other organisations, is that the aftercare program is funded by Northwest Melbourne Primary Health Network as part of the trial, as this project was, and it's been an amazing to be a part of that journey with Mind Australia, Izzy and their team. So I think the importance is, if you want to actually pick something up and like this, an aftercare program, for instance, and start in another regional area, another state, yeah, you need some guidance, because there isn't much there. Well, the actually part of the trial is have created a trial guide. So Izzy and her team and Impact Co have actually developed a guide that will be available, widely available, free resource, and it actually steps you through how the important things to think about, and what do you need to do to provide a successful aftercare program for LGBTIQ communities. So that's one thing that I'll put my email in the chat, and people can get in contact with me. We'll be launching that probably next year now, so given it's nearly December. And also we would also have, it's every organisation's responsibility to actually educate themselves and their staff on how to work with queer community. It's not about just the specialist organisations should know what to do. Anyone who walks in your door needs to know that it is a safe space, no matter what service, especially mental health. But so there is free training, and we also have developed an affirmative practice online training module that can give an introduction for services to how to create an affirming workplace for your staff, for your clients, for anyone who enters your doors. So again, Thorn Harbour Health have created that, and it's an online free resource to anyone who would like it. And again, get in contact and I can do that. I'm sorry, there's a whole heap of other things, but I think also it's about partnerships, really creating partnerships with the community controlled organisations, the organisations who who provide services to queer communities as part of their core business, and mainstream services. You can learn so much by just asking questions and being respectful, and sometimes it doesn't have to be a lot of work to provide a welcoming environment. It's not just about putting a flag on the door. Yes, I think it's a great, I look for it, I certainly look for that rainbow sticker, but there's more to it. And there's certainly ways that you can actually improve that for community. And there's another thing is in relation to some suicide prevention training as well for LGBTIQ people that we've adapted. It's Assist, it's Safe Talk, it's Start. So this is all suicide prevention initiatives. So and that's all free at the minute through us as well. So I guess what I'm trying to say is it's not that hard to take the first step. Sometimes it can feel a little bit overwhelming.
Amber, can I just build on something Jo said there?
Please do. Please do.
Oh, sorry. Thank you. Just Jo made that point about the suicide prevention training just reminded me to say that it's, you know, it's absolutely essential that we start, that we continue to think about how services can be more affirming of LGBTIQ people in relation to their mental health, so that communities don't have to depend upon one another to quite the extent that they are. But at the same time, that process is going to take, is ongoing and will continue to take more time than ideally it should. And what I guess I'm mindful of is how we need to be ensuring we're supporting people who are providing this kind of mental health support right now. And that training that Joe was speaking to there, I think, is a really, really important part of that. If there are people within community who find themselves on a regular basis providing this kind of support, well, then having some training around how to recognize and respond to suicide or potential suicide among friends or family members, I think, is a really, really crucial thing. Understanding where you might be able to refer to for kind of, culturally safe and affirming sources of support, I think that's really important as well. And I think outside of kind of formal service provision, I think there's a role for doing things like, creating guidance or resources that people can access, websites or booklets or whatever format it needs to be in, that just help people who find themselves in this role currently. They find themselves providing support to other people, and maybe they need some advice around, how to craft some boundaries around that role that they're performing, how to kind of undertake some self-care, how to recognize other challenges that they're being presented with, and know who they can go to for support if they need it. And I think actually in that respect, there's a role to be raising awareness of the ways in which existing services can be a source of help. So if you rang up Rainbow Door through Switchboard here in Victoria at the moment, and you were the person providing this kind of mental health support to others, they would talk to you, they would advise you, and they would assist you as best they possibly could. But I think people don't always necessarily realize that that kind of support exists for them as well as the support provider. So I think I agree with absolutely everything Andrea and Joe were saying around the need for reorganizing services to be more affirming. But I guess at the same time, we need to be dealing with the situation we have right now, which is people providing a form of mental health support which isn't necessarily recognized, which they're not necessarily always well equipped to perform. And perhaps we need to be doing more at this moment to ensure that they have the resources and the skills available to them and the support around them in that really, really crucial role that they perform.
And sorry, Amber, I just will sort of follow up on that. So as one of the recommendations from the Lean On Me report was to actually provide, to build the capacity of our community to respond to these issues. And we've actually been able to do that, from this report. It's the PHN, and we've actually continuing to fund Living Works to actually provide this training for the next 12 months, not 12 months now, but and we really will be focusing on community. So we've been doing this in the last couple of years for organisations, mental health organisations, frontline workers, things like that. But we really want to try and really reach people who really need it and who are actually providing this support now. And even just doing an online 90-minute start can actually help. It's not going to be everything, but it will help, and it will take the burden off you, because then you'll have that framework on how to deal with that. So yes, keep a watch out for that. It is only in our region at the moment. I'm really aware of that, but hopefully Living Works can have doing a wonderful job in adapting this training for the LGBTIQ community. So hopefully it will go a little bit broader.
That's brilliant. And I know that 2010 here in New South Wales, where I'm based, have been doing some really excellent work around offering the Living Works package suite to folks too. So if you're in New South Wales, that's definitely one place that you might look to for some of those resources. I want to go back to something that we talked about at the beginning of the session, which was some of those positive benefits to peer support and the strength that that has in our communities. And I'm wondering, maybe Adam, we'll start with you with this one, what service providers can learn from those positive benefits and how they can incorporate that into their service delivery.
That's a wonderfully creative question, Amber, to which I need to take a moment to think about it. I hadn't really thought about it from that perspective.
Do you mind if I jump in?
Yeah, please do, Joe. You might have a time where I don't.
No, I think, look, when we were looking at doing this research initially, whenever I spoke about peers, the organisational focus went to peer workers. It's a completely different environment. So what we can learn is that there's different levels of support. People need different things. It's not one, no, it's not peer workers and everything has to be paid and that, because it does take away the relationships and the trust that is provided. So I think, one, we learned that it's important to know it's happening and maybe ask the question, who is providing support to you when people you do have that maybe conversation as from an organisation's point of view, so you can understand who is supporting this person, who has kept this person going for the last 5 years. I mean, the research is showing that people are providing this support for years. We're not just talking a one-off incident, we're talking of years and years and years of support, informal support. So understand that and actually acknowledging that person, that person's life is really, really important, and you'll actually be able to see that the relationships will actually be mutual, and it will be actually, if you can actually walk alongside that, then you can help both.
That's great.
I jump in, or Adam, did you want to? No.
Please do, Andrea.
I was going to add to that as well. I mean, one of the things that I think we've learned from this research and kind of reflecting more broadly on the community is that peer support is about, for me, it's about getting rid of hierarchies that can often exist in medical and health systems. And those hierarchies can make someone feel invalidated, dismissed, ignored, inferior, pathologized, all of those things. And that can make getting support when you're already feeling vulnerable even more difficult. So when you're talking with someone who knows you or understands you or can in some way sympathize or empathize with your experience, those hierarchies are taken away and you're treated as on an equal term. You're treated as a human being. You're acknowledged as a human being. You're not just a number. You're not just another case coming through the system. And I think peer support does that exceptionally well, because you see the person as a whole. And that is so important when you're helping someone with a mental health concern, mental health distress, because they themselves may not be able to see themselves in that way. They may be significantly struggling to see themselves as a whole person, to see themselves as beautiful and valid and wanted in this life. And so I think peer support does something there that services can also take from, which is getting rid of some of those hierarchies and actually meeting with the person on their level, engaging with them on their level, and understanding them to then help them find the best support, rather than just saying this is the best support that you need. It's about, what can we do that's going to help you, that you feel, here are some suggestions, let's work and find a solution that works best for you in that situation. And there's that diversity of approach as well. So I think that's something that I think the report kind of speaks to, but also just kind of reflecting on that beautiful history of peer support in this community.
And Amber, sorry, I will jump in there. And I think also, I know if we're from community, so we sort of, maybe this is just, we understand that given that not everyone from our community has their family with them, or has the, so that the family of choice is so important for our community. And, if someone walks in the door and says that their housemate is their support and they have every right to be in the room with them, listen to that, because this is the one person who is possibly keeping this person well enough to walk in your door. So I just think, that those typologies that the report has shown is that there's 6 of them. Sorry, Adam, 6. And that there's such a diversity of support being provided by different people, and please acknowledge that.
Absolutely, yes. And Andrea, I think it's really important that we acknowledge the history of peer support in our communities. And so thank you very much for flagging that. Look, we're nearly coming to the end of our session today. So I think I'll just go ahead and ask folks to do a round robin of any final reflections that they've got before we close off for the session today. Adam, shall we start with you?
Thanks, Amber. Look, I mean, my closing point will be to say that we have to always maintain an emphasis on primary prevention. Andrea alluded to this in something she said earlier. We would not be in this situation if it weren't for pronounced homophobia, transphobia, biphobia, all other forms of phobia and discrimination directed at our communities. Until we tackle that, until we improve the environment within which LGBTIQ people live, we will continue to have these conversations, and we shouldn't have to have them in the first place. So I guess I just really wanted to underline that point that was made a moment ago. And maybe just while I've got the microphone, just to say again how grateful I am to you and to Ash and to Yeshim for organising this event and giving us the opportunity to showcase a little more Lean On Me, and to say a very public thank you to Joe Reed, who's been the most fabulous contract manager I've ever had in any funded project. It's been an absolute pleasure to work with. And also just finally to, in addition to Andrea Walling, who was a co-author of the report, just to acknowledge Chris, Anthony, Joel, Jackson, and in particular Shane Worrell, who was the lead kind of project manager on the study and really helped to make it happen. And it was Shane who listened to and carried all those really, really challenging stories that people were articulating around their mental health experiences and that experience of supporting others. And he did a great job. And so I just wanted to make sure Shane got a shout out in this webinar for that.
Thanks, Adam. Andrea, is there anything that you'd like to add before we close out?
Yeah, just quickly echoing all of Adam's comments about the event today, about the amazing work that we got to do with Joe. I had a fabulous time working on this project with Joe and everyone. And again, to thank all the co-authors and Shane in particular, who just carried this whole project with such grace and ease and just was just fantastic in running it. And I think I just want to kind of reflect a little bit more on that history. I think it's so important that we always remember that this community across the globe has a beautiful and complex history of peer support, from fighting back against AIDS and HIV discrimination, from supporting each other during the epidemic when we didn't know what was happening or why it was happening, from creating safe spaces to exist when it was criminalized, to be who we are. And now we're seeing that coming through again in the kind of peer support for mental health and suicide prevention and just in all kinds of things today. And I just think this report and this research is just a little part of what is a massive, beautiful legacy of community that we see. And it's just such a pleasure to be a little bit of part of that, and to see all the amazing work that I see in Melbourne and across Australia, all the different kinds of LGBTIQA+ groups that are supporting each other, that are doing different things to help each other out, that are running all kinds of different programs, from dealing with housing crisis, to employment, to mental health support, to friends and family, to dating, to just social events. Like it's absolutely incredible. And I just think if we always remember that legacy and push forward, I think it's a wonderful thing. Thank you.
And Joe.
Well, first of all, thank you, Adam and Andrea. It's I've absolutely loved this project. It's one that I've completely started when I first started to now today. So I have it's just been an absolute privilege and to work with ARCSHS and both of you and your team and Shane. I would probably just like to say also thank you to all the voices and everyone who participated, completed the surveys, who did the very in-depth one-on-one interviews with Shane. If you haven't read the report, I really encourage you to do so. It's really well written. It's the lived experience voices comes through loud and clear, and some voices we haven't heard from within our community. So yeah, thank you to everyone. And I guess my commitment to our community is that we'll continue to, at the PHN, to listen to the lived experience and ensure that everyone is heard. It's not always easy, but you know, we'll hopefully continue to do so. And thank you to you and your team, Amber. It's been great working with you all. Thanks.
Thank you so much. Thanks, Adam, Andrea, Joe, the MindOut team, our Auslan interpreters, and to everyone for being here today. Really, really appreciate it. Yeshim, would you like to wrap this up for us?
Yes, I would, although I think you've all covered everything that I did want to say, which is basically just a big thank you to everyone involved, especially Martha and Izzy, who were in our videos, and as well to those interviewed for the report itself. It's quite an important piece of research, and I'm really happy that we got to shine a light on it. If you do want to see any more of our projects, please visit the LHA website. We've got some future webinars planned, so keep your eye out from the MindOut team. And don't be shy to reach out if you want to hear anything else that we've got coming up. You can just email us. We also offer some training as well, and that's nationwide. So you're able to look at our content there if you're in other states outside of Victoria. And I just want to say again, if you've had any strong reactions to any of the content, you're not alone. We're all feeling this. I want you all to please take care of yourselves and to reach out if you need it. And thank you. Thank you to everyone involved. That's it. And thank you to our Auslan interpreters. It is very difficult to interpret a webinar, so good job. All right, bye.